Our next speaker will be Dr. Patricia Ford, speaking on erythropoietin for the cancer patient to give or not to give. Dr. Ford is an associate clinical professor at the University of Pennsylvania School of Medicine in Philadelphia. She's a member of the medical staff at Pennsylvania Hospital in the Division of Hematology and Oncology. She's the medical director of the Center for Transfusion-Free Medicine and medical director for the Autologous Transplant Program, for which she performed the world's first and largest series of transplants without blood product support to Jehovah's Witnesses. She is also the medical director of the Clinical Research Unit at Pennsylvania Hospital. She received her medical degree at the University of Miami and completed her postgraduate training in medicine and a fellowship in Hematology-Oncology at Fox Chase Cancer Center. She's board certified in internal medicine and both hematology and oncology. She's a founding member and past president of SABM. She's currently a member of the American Society of Clinical Oncology, the American Society of Hematology. Her areas of interest in oncology are bone marrow transplant and the treatment of women with breast and gynecologic malignancies. She's also focused on patient blood management and alternatives to transfusion support. She has an interest in benign hematology, including the diagnosis and treatment of anemia, especially iron deficiency in pregnancy, managing coagulopathies, and thrombosis. Welcome, Dr. Ford.
Thank you very much. Slide? Yes, I will. So thank you so much for that nice introduction. Let me share this. And let's go up top. Yeah, it's kind of hiding it, isn't it? I'm running into the same problem as our other ones. So let me find our first speaker. It kind of hides your slides. So let's. It'll be up there. Let's try this one. Nope.
Under slideshow usually?
Yes, it's up top and I'm running into the same thing. It's kind of hidden, but let me do.
You have it down at the bottom. See at the bottom next to the volume.
Yep, let's go down there and see what's down there.
The very first one, next to the volume.
Down to the volume now. Let's try down here.
Yes.
Yep. Okay, thank you. Thank you very much for that nice introduction. And this was great. Those first two discussions were wonderful because they really do put a nice segue into what I want to talk about, which is erythropoietin for the cancer patient, to give or not to give. My financial disclosures are listed in terms of advisory and consulting. And I just want to start by saying, what is the ongoing dilemma with erythropoietic stimulating agents? Well, if we treat with them, a lot of physicians know that we have potential risk, increasing thromboembolic events and potentially worsening cancer outcome. If we withhold erythropoietic stimulating agents, then we increase the need for transfusions and associated risk. Ongoing anemia symptoms will also cause a decrease in quality of life. And then we have a potential dose reduction, which can worsen cancer outcomes. So if we have to delay our treatment options, obviously that's not good. So our objectives here is going to be to analyze the benefit and risk in the management of associated anemia with ESAs, summarize ASH and ASCO clinical practice guidelines, and then we're also going to look at describing some of the erythropoietic dosing, modification, and concurrent iron deficiency. So you can see how we had some of this already for our discussion, and it was great. I'm just going to kind of highlight and build. So this is kind of a fun slide here, the history of erythropoietic agents. If you look over on the left, you can see the first time there was even a suggestion that there might be a hematopoietic factor controlling red cells was in early 1900s. But it wasn't until 1953 when this factor was confirmed and given the name erythropoietin. And then eventually in the 70s, we found the ability to isolate this protein from urine, and that's going to lead to the cloning of the gene. And then the ability to produce recombinant human erythropoietin, which was FDA approved for the first time in the early 1980s in chronic kidney disease. In 2000, we had second generation FDA approval here in the United States. And then in the early 2000s, we started to see these safety issues emerge with the use of erythropoietin, especially in oncology patients and chronic kidney disease also. There was a large study called the BEST trial, which is breast cancer erythropoietin survival trial. And there was another one reported after that, the ENHANCE trial, which is looking at erythropoietin in head and neck cancer patients. And in both of these, there was a decrease in overall survival and an increase in local regional cancers. I will highlight in these early studies, they targeted very high hemoglobin levels. But this led to a black box warning and the institution of a REMS program, our risk evaluation and mitigation strategy, which was great because it really did have us really fully inform our patients through counseling about the risks and benefits. This was actually lifted in 2017 because at that point, it was felt no longer necessary as providers had demonstrated knowledge of the risks, and there was data supporting the fact that we were using it more appropriately in our practice. And then also moving forward, you can see the FDA approval of biosimilar agents. So let's just talk a little bit about the erythropoietin gene and receptor itself. It is located on chromosome 7. The expression is regulated by hypoxia, and it's produced mainly by the renal cortex. The receptor itself is located on the cell surface of our erythroid progenitor cells. And as you'll see in a couple slides, that leads to promoting survival, proliferation, and differentiation. But quickly we realize this receptor is also expressed in other organs: brain, heart, liver, kidney, and various cancers. This just kind of highlights for you the signaling pathway here for erythropoietin. If you look, you see some very important signaling pathways that are also important in cancer. But here, specifically looking at our erythroid progenitor cells, you can see down the bottom, all these pathways lead to increased proliferation of those cells, survival, differentiation, and more proliferation. How about the receptors themselves? So again, on the left was what we just highlighted, but how about in all these other organs that we just talked about that are not cancer? There may actually be some data out there to show that there's some use of erythropoietin in terms of tissue protection. So let's start talking about anemia of inflammation. And that's been highlighted already by our previous speakers, but just to stress again that anemia of chronic disease or inflammation is the second most prevalent anemia, especially common in cancers. As mentioned, prevalent in 40% of our oncology patients, 75 to 90% once we place them on chemotherapy. And because I'm going to be talking about that in the future, and about 90% in those individuals with myelodysplastic syndrome. Our current treatment with erythropoietin has limited response, but we also know that anemia leads to poor quality of life and exposure to transfusion risks. So as mentioned, there's many different causes of cancer-related anemia related to our underlying malignancy, and at times, especially with the hematologic malignancies, hemolysis, and then add on that our cancer treatment with myelosuppressive drugs and radiation. Perfect case study that was just shown, demonstrating there also can be occult blood loss in our cancer patients, which I see a lot in our GYN malignancies that have had cervical cancers, other cancers with ongoing blood loss, and in our GI malignancies. Nutritional deficiencies, as our patients eat a little bit less, get a little more anorectic, we can find B12, folate, and iron deficiency. And occasionally in this older population, you may also be dealing with underlying chronic kidney disease. So this pathophysiology of anemia is related to impaired proliferation and differentiation in our erythroid precursor cells, as well as the inhibitory effects of things that are released by the cancer cells themselves, interferons, tumor necrosis factor, and cytokine-mediated apoptosis. All this leading to a blunted erythropoietin response, and impaired iron hemostasis, why that first presentation was so important. The increased expression of hepcidin causes a downregulation of iron absorption, which makes it very difficult on these patients to really replenish iron stores with oral iron. And there's also this impaired recycling of iron from our macrophages. Hence, you can have a high ferritin level because you got adequate iron stores, but you're just not moving them into the erythroid progenitor cells. And this is just a nice, by Dr. Goodnow, kind of schematic of all that we talked about, showing up the top right, the liver, and the importance of the most important regulator we now know in iron, which is hepcidin, and its impact down the bottom on the bone marrow. So I'm going to start talking a little bit about the American Society of Hematology and American Society of Clinical Oncology updates, but what led them to need a new update? So they put out their first guidelines around 2002, and since then there's been 2 updates. This will be the 3rd. So what caused these societies to say we need to have another update? And it was really based on 3 additional information that came out. Number 1, they wanted to look and see the articles that were more recently published on the use of ESA, and was there anything that had changed in the knowledge we already had? And they added and focused on some of the studies which I'm going to review in metastatic breast cancer and MDS. They also wanted to highlight the role of iron and the benefit in using it with ESAs, and then needed to acknowledge the fact that there was also now an FDA approval of biosimilars. So these guideline updates were an expert panel convened that reviewed randomized controlled trials, which there were 15 new ones since the last update, meta-analysis of randomized controlled trials, of which there were 2 in patients with cancer that were published from 2010 through 2018, and they decided to address what they felt were 10 very relevant clinical questions. Clinical question number 1. To reduce the need for red cell transfusions, should ESAs be offered to patients who have chemotherapy-associated anemia? And in this, there was one study that was also, there were a few studies that they looked at. I'm going to highlight this one here, which is looking at one tumor type, metastatic breast cancer. And remember, I had mentioned one before called the BEST study, and I'll come back to the comparison between that one and this one. So this study here was an open label, non-inferiority study in women with a hemoglobin under 11. And most of the time, the median baseline was 10.5. And these individuals were given erythropoietin, 40,000 units weekly. And they ended up given a median of about 8 doses. And it was randomized against best supportive care, which included iron and transfusion support. And you can see it's a large study. It's 2,098 patients. Their primary outcome that they wanted to look at was progression-free survival. And what they found here was exactly the same, 7.6 months in the ESA treated versus best supportive care groups. They also wanted to look at overall survival. And it was 17.2 versus 17.4 months. So again, you can see not statistically different here. So they felt at this point it did not meet, of course, their non-inferiority criteria. Other secondary outcomes that they looked at were transfusion, decrease in transfusion requirements, and it was low in both groups, surprisingly. In the ESA treated group, it was lower at 5.8%, and in the best supportive care was 11.4%. The median hemoglobin that was achieved was higher in our ESA group at 11.6, and our best supportive care group was 10.9. The other thing they looked at was thrombosis. And it was low in both groups, much lower than some of the original studies that led to the increased risk of thromboembolic events. It was 2.8% in the ESA treated group and 1.4% in the best supportive care group. Anytime the TSAT was under 20%, both groups received iron, and the majority of the time it was oral iron. So what I wanted to highlight here was the fact that compared to that BEST study that was done a number of years ago, why is there a difference? Why did they not see a decrease in overall survival or progression-free survival in this larger study? Well, there's a couple of thoughts. One may be that in the initial study, their use of ESA was well beyond what we would normally be doing now. Right now, we're just looking to correct the anemia and avoid transfusions. So as I'm going to get to, it's not even approved if your hemoglobin is over 10. So the older studies really ran the hemoglobins much, much higher with ESAs. Why could the thrombosis be lower? One thought is that in this study, there was an extremely strict definition of what constituted thrombosis rather. So they did not include, for instance, something that was more likely superficial phlebitis. So the recommendation from this was that ESAs can be offered to patients with chemotherapy-associated anemia if there is no curative intent and if the hemoglobin is under 10 grams. So this was just, nothing new was found in terms of the risks, essentially, and they kept their kind of recommendations very attuned to the ESA guidelines before. Clinical question number 2. To reduce the need for red cell transfusions, should ESA be offered also to anemic patients with cancer who are not receiving any concurrent myelosuppressive chemotherapy? And really, I wanted to stop again just to highlight the difference between hematologic malignancies and solid tumors, because there can be differences here. Certainly in our solid tumors, it can be a direct effect of the cancer itself from bleeding, as I mentioned in GYN, GYN. So you may be dealing with a larger component of absolute iron deficiency here. Usually the nutritional deficiency can be more common in our GI tumors that are associated with malabsorption. And the thing to highlight in some of the hematologic malignancies and disorders is you have bone marrow infiltration, our leukemias, our lymphomas, our myelomas. You can also have hemolytic anemia, autoantibodies, microangiopathy, and amyloid production. So there are some other reasons to add on why we could have anemia in our hematologic malignancies. And why I bring this up is in this recommendation, they now wanted to look at myelodysplastic syndrome. So remember, with myelodysplastic syndrome, this disease, it's very common in our low-risk population. For the most common thing that we're dealing with is symptomatic anemia. And ESAs are our standard of care. Now, in the 5q deleted patients, we use lenalidomide as a treatment option because we know that lenalidomide is cytotoxic to the MDS clone. So that population was not allowed in this study. So as you can see, they're going to look at lenalidomide with or without ESAs in patients that are transfusion dependent and have already been exposed to ESAs and are refractory, but are still in our lower risk MDS. So in this study, randomized phase 3, they looked at about 131 patients that were transfusion dependent, getting upwards to 6 units of blood in over a 2-month period. Everybody got lenalidomide, and then it was randomized with or without erythropoietin at 60,000 units per week. And what they found was that the transfusion independence rate was much higher when erythropoietin was added to this difficult to treat transfusion dependent and refractory population. And remember, in MDS, these patients are anticipated to have a very long survival. So we want to try to avoid transfusions and the risk of iron overload, which is another very important complication in this patient population. So the recommendation for this clinical question was that ESA should not be offered to most patients with just without chemotherapy-associated anemia, with an exception of lower risk MDS, and in that case also found to be most beneficial when the erythropoietin level was under 500. Their next clinical question was, what special considerations apply to adult patients with non-myeloid hematologic malignancies receiving concurrent myelosuppressive chemotherapy? And here what they wanted to look at is our hematologic malignancies, multiple myeloma, non-Hodgkin's lymphoma, CLL. And what they wanted to highlight here first was try treating before you're going to add on ESA for the anemia, because these diseases can be very responsive to all the new agents that we have. And, all of us have examples in those who decline transfusion, presenting with very profound anemias. I'm treating someone right now who's a Jehovah Witness with a new diagnosis of multiple myeloma, coming in with profound anemia, hemoglobin just under 4 grams per deciliter. And in that individual, they're getting a very nice response with steroids and my non-myelosuppressive agents, and already I have a hemoglobin without ESA, without iron replacement, just with treatment up to a hemoglobin of 8, which will allow me to come in with more cytotoxic agents. And also in this population, they're just highlighting again even more caution because of the thromboembolic risk. Think about some of these diseases and the strategies we use, like lenalidomide, that do increase thrombotic risk. Question number 4. What examination and diagnostic tests should be performed before making your decision about using ESA? to help us identify patients who are likely to benefit. So what they're trying to do here is really, as has been discussed, look at, are you sure you don't have an alternative reason for your anemia? Great case study, exclude occult blood loss, renal insufficiency, hypothyroidism, and of course, like we all do, evaluate for hemolysis or underlying hemoglobinopathy, along with the basic things we do, which is iron, folate, B12, reticulocyte count, and review of our peripheral smear. So again, they just really wanted to highlight to make sure that we're identifying alternative causes of anemia. Clinical question number 5. Among adult patients who receive an ESA for chemotherapy-associated anemia, is there any difference between the many different agents we have available now and the currently available biosimilars? And is there any difference in respect to safety or efficacy? So here they actually, when they looked at the biosimilars, I'll just highlight the fact that they included a few studies, randomized clinical trials with CKD only. They just needed to get more robust information on our biosimilars. And I'll stress the fact there's limited evidence, but these agents have been more widely used and longer history in Europe than here in the United States. And of course, for all of these, how we make the decision is if they're all equivalent, and that was what they decided on review, is that there was no difference in efficacy or safety. We now have a choice, and we all use the choices we have available to us based on cost. It may be cost factor, availability, or convenience from some of our longer acting agents. But again, to highlight, no difference in efficacy or safety. Clinical question number 6, do ESAs increase the risk of thromboembolism? So we've known this since the early 2000s, and what they wanted to do was just see if there was any new information that came out. And essentially, I'll highlight this one, which is one of the new studies that they looked at from Gal. This looked at 12,000 patients, venous thromboembolism and ESAs for the treatment of cancer-associated anemia. This is a meta-analysis. And they're looking at the incidence of VTEs, and you can see with ESAs, 7.7%, our control, 4.7%. Now, remember the study I presented with breast cancer? That also was a large number of patients. It was, just one study. But why are all these differences there? So one thing with you're looking through all this robust data is to keep in mind, not many of them. There's so many different cancer types. So we don't have a lot of information on individual cancer types and the effect of ESA and the ESA risks. So we do see differences here. And the other thing is when we get to it, a lot of the earlier studies especially did not really differentiate between curative and palliative intent, which is where we're restricted in our use of ESA. They did highlight the fact that our highest risk of VTE, again, was with hematologic malignancies, and they also broke down ovarian and cervical cancer, our GYN malignancies. So the recommendation here was there was no difference in the data in terms of the increased risk that is seen with the ESAs, and that we should continue to use that with caution. Clinical question number 7. Among adult patients who will receive an ESA for chemotherapy-associated anemia, are there any change in the recommendations for ESA dosing and dose modifications? So there's not. The recommendation was to continue to follow the FDA guidelines in terms of dose increasing, reductions, withholding, and discontinuing. And I think another thing to highlight in a lot of these studies, yes, the dosing is different, so it's hard to do any comparison. In a lot of the older studies, some experts have said that was the reason they may have seen such a high rate in the VTEs, especially, was they were running the hemoglobin way higher than it needed to be, with targets upwards to 14 and 15 in some of those studies. And we've learned from that, we want to keep the dose what is absolutely necessary to avoid transfusions and not to overshoot. And we want to decrease the dose when we reach a level to avoid the transfusions, or when our hemoglobin increases 1 gram per deciliter in 2 weeks. Because another thought is that there may also be a too rapid increase in the hemoglobin, may also be leading to some of these VTEs. Their clinical question number 8. among adult patients who will receive an ESA for chemotherapy-associated anemia, what is the recommended target hemoglobin? Do we have a recommended target hemoglobin? Remember, their ESA guideline is that we start only when our hemoglobin is under 10, and we use it only in the non-curative setting. So they did not come up with an optimal hemoglobin defined, other than to say the target should be the lowest dose, the lowest hemoglobin, you need to avoid or reduce red cell transfusions. And to strongly consider modifying your dose when your hemoglobin exceeds 1 gram per deciliter increase in any 2-week period, a too rapid rise in that hemoglobin rate. Question number 9 out of 10. Among adult patients with chemotherapy-associated anemia who do not respond to ESA therapy, and that definition is a 1 to 2 gram increase in hemoglobin or no decrease in your transfusion requirements, is there any benefit to continuing ESA therapy beyond 8 weeks to provide a benefit? And the recommendation is there should not be continuation if you have no response in your patients beyond 6 to 8 weeks. And as we've mentioned before, of course, at this point, you're also going to be, again, looking at alternative causes for your anemia. The last question. Among adult patients with chemotherapy-associated anemia, does iron supplementation concurrent with ESAs reduce your transfusion requirements? And as been mentioned, we now know a lot more about absolute versus functional iron deficiency, and we do see absolute iron deficiency in this patient population. I mean, of course, we're used to it. For those of us who treat a lot of women with GYN issues and heavy uterine bleeding, we're used to seeing our ferritins of 1 and 2 with our profound anemias, but you can also see absolute iron deficiency in our patient population of cancer patients. Functional iron deficiency also incorporates iron-restricted erythropoiesis. So as we're giving erythropoietin, we need to make sure, even if we started with adequate iron stores, we're likely to outstrip that if we don't give available IV iron necessary for that enhanced red cell production. So looking again, a few studies were already highlighted in terms of iron supplementation, adding it on to ESAs. I just listed a few here. And let's look at Petrelli's, the addition of iron to erythropoietic stimulating agents in cancer patients. This is a meta-analysis of 8 trials. And the comparator here was no iron versus oral iron versus parenteral iron. Over 1,600 patients out of these 8 trials. And what they showed here was there was an improvement in hematopoietic response with parenteral iron much higher than for oral iron. And the risk of transfusion was reduced with parenteral iron, but not with oral iron. So parenteral iron preferred. And the time to reach hematopoietic response was much shorter, over 1 month, with iron supplementation. So overall, parenteral iron reduced the risk of transfusion, increased the chance of hematopoietic response when compared with ESAs alone. Oral iron did not increase hematopoietic response nor decrease our transfusion rate. And think about it, that makes sense in terms of what we all know now about functional iron deficiency and decreased iron absorption. And the significance of this result is the proportion of non-responders to ESAs will have strongly improved and quality of life and cost ameliorated if we can add iron, parenteral iron, and get our response. Looking at a subgroup analysis and a concurrent review, looking at 8 randomized clinical trials, comparing ESA plus iron versus ESA alone, over 2,000 participants, again, highlighting almost the same thing, the beneficial effect of iron supplementation to ESAs, decrease in red cell transfusion, and in their subgroup analysis, the fact that intravenous iron was favored over oral iron. Their author's conclusion is highlighting what we've already seen, the addition of iron to ESAs will give you a superior hematopoietic response, decrease your risk of red cell transfusion, improve your hemoglobin level, and appears to be extremely well tolerated. With no evidence, unfortunately, in some of these, it varies for a difference in quality of life with iron supplementation. This is just looking at what's our future look like. So even this slide is a little outdated already. What are some new compounds under development you should keep your eye out for that may supplant ESAs or assist with ESAs? So as we're learning more and more about hepcidin, that may be a mechanism that we can target. As we're learning more and more about the whole pathway of iron and more about erythropoietin and receptors. So there's a lot on the horizon here and compounds that are under the development for the treatment of inflammation and malignancies. So in conclusion, the use of ESAs to manage chemotherapy-associated anemia will raise the hemoglobin level, decrease your transfusions, but does come with an increased risk of thromboembolic events that we need to be very cautious about. We have guidelines that have been updated supporting the offering of ESAs in a non-curative setting and when the hemoglobin is under 10. Adding iron to treatment with ESAs may improve the hematopoietic response or reduce transfusion. And I think ongoing studies are really needed to look at different malignancies, which may render different responses. And we need to be very careful to look at these studies and have it randomized so that we know if it's being given, if our chemotherapy is being given in a curative or a palliative setting. So thank you very much.